Next presenter, Dr. Nikita. Dr. Sumit Patil is he here? Dr. Sumit Patil. Dr. Avnish Upadhyay. Dr. Jitendra Kumar. Okay, you can start.
Good afternoon, everyone. My name is Dr. Nikita. My topic for today is snake-like pattern on retina, that is serpiginous choroiditis. This won't move ahead. Move. Sorry. Okay. Serpiginous choroiditis is an inflammatory disease characterized by geographic pattern extending from the peripapillary area, that is from the optic disc, up to the RPE and outer retina in a centrifugal manner. It is recurrent and progressive in nature. It is responsible for less than 5% of the posterior uveitis cases, commonly seen in young middle-aged adults, and the male predilection is more common than female, and it has bilateral presentation as well. It may be infectious or non-infectious, and in infection it is associated with syphilis, tuberculosis, herpes, and might also be associated with HLA-B7. The main etiopathogenesis is the involvement of the RPE, the outer retina, and the choriocapillaris. Incidence in India is approximately 5 to 8%. We present a unique case of a 28-year-old male who presented to OPD with complaints of diminution of vision in both eyes since few months. Patient had no other complaints than diminution of vision. There was no history of systemic illness and no history of ocular trauma or previous surgeries in the past. But patient had a past history of tuberculosis, which was approximately 6 years ago. On clinical examination, the visual acuity of right eye was 6 by 18, improving to 6 by 9, and of left eye was 6 by 60, improving to 6 by 18. EXOM were free, full painless in both eyes, and the anterior segment examination of both eyes was within normal limits. On posterior segment examination of right eye, the media was clear. Optic disc showed peripapillary atrophy with CD ratio of 0.4:1 CTR, along with temporal pallor. AV was attenuated, FR was dull, and the macula showed old choroiditis patch extending superotemporally and inferonasally along the vascular arcade and extending in a serpiginous manner. That of the left eye, the media was hazy. The optic disc showed peripapillary atrophy along with temporal pallor, and the macula showed tractional bands along the superior temporal arcade involving the macula. The lesions were well circumscribed, grayish yellowish lesions suggestive of chorioretinal atrophy. Few healed atrophic lesions were also present, which were in a geographic pattern extending towards the macula, involving the fovea and the parafoveal region. This is the fundus photograph of the patient. Laboratory investigations were within normal limit. The patient had no evidence of any active infection, and patient was treated with oral steroids and immunosuppressive therapy was given. Patient was advised refraction and was counseled for follow-up after a few weeks. The main treatment goal is to suppress active inflammation and reduce the recurrence rate. A combined regimen of corticosteroids and immunomodulatory agent is very important, along with adjunctive treatment with anti-angiogenic factors. The most likely hypothesis behind serpiginous choroiditis is that it has an autoimmune correlation or might be idiopathic in nature, when not related with any systemic or infectious cause. The most common complications could be either choroidal neovascularization, cystoid macular edema, branch retinal vein occlusion, optic disc vascularization, or serious retinal detachment. In chronic long-standing cases, long-term treatment is required with steroids and immunosuppressive agents. The patient usually has a poor outcome in such cases. I would like to conclude that based on clinical findings and investigations, 28-year-old male with bilateral posterior segment findings without any other present systemic illness is a case of bilateral serpiginous choroiditis. The findings were confirmed with fundus photography and OCT. Follow-up was advised to the patient after a few weeks. Thank you.
I would like to ask Did the patient had any active inflammation? Because the fundus photo was showing there were scarring all over there.
Ma'am, there was no active inflammation. The patient had a past history of tuberculosis 6 years ago.
Then why did you treat him with the oral steroids and immunosuppressants?
Ma'am, earlier in the fundus photo of the right eye, according to the faculty that I had shown, they were of the opinion that patient didn't have active lesions. But on further routine examination, we found out that those were just the choroatrophic patches.
When the patient is having healed choroiditis, I don't think we should treat him with oral steroids.
Ma'am, the patient had a past history of arthritis as well. So because of
So
that,
he
ma'am,
must be having some medical treatment for arthritis.
yes, ma'am. So, ma'am, we had referred the patient to the rheumatologist. So, according to that, they started the patient on oral steroids, ma'am.
Okay.
How can you confirm or differentiate between active and the healed lesion by doing any investigation?
So, we had an option of fundus fluorescein angiography as well, but the patient was not giving consent for the same, so we couldn't.
Anything apart from FFA which you can do to differentiate?
So, based on the lesions also, like the margins of the lesions would be more enhanced and would be elevated, and as compared to the active lesions would be present at the periphery of the old scar.
Does autofluorescence have any role?
Yes, sir, it does.
Do you have that in your institution?
Sir, we did not, so we couldn't perform it.
We can
Thank
do follow-up of these patients by autofluorescence also.
Yes, ma'am. Ma'am, actually, eventually, in a span of a month, we lost the patient to follow-up because the patient was originally from Bihar. So, on a routine OPD examination, we diagnosed this, and then afterwards, in a period of a month, we lost the patient to follow-up.
Thank you.